I will be demonstrating how to check in a patient for surgery. We have our charts pulled that are for surgery. They are in the front. So when the owner and their patient comes in, we pull their chart. We have a few different forms for the owner to fill out. For this example, I'll be using a patient that we recently performed a neuter on. His name is Ace Bott. He is an 11-month-old male husky mix with no previous health issues. We have our surgery consent form. This is the main form that we have the clients fill out. It details the surgery to be performed, the patient's name at the top, the date, and the weight which we will get on the day of surgery. The client will initial at the X's to consent to the neuter, as well as an IV catheter and fluids, pain and comfort medications, and e-collar. And on the back side, pre-anesthetic blood work, which we have already completed. They can opt to receive the laser surgery for their pet. This is, instead of a scalpel blade, we use a surgical laser to make the incision. And another option is the microchip, which they can opt to get or not. At the bottom of the form, we take the client's phone number as well as their signature, so we can contact them when the procedure is finished or if there are any questions or concerns. The second form we typically give the clients is a copy of the estimate. It just has an itemized list of everything Ace would be receiving that day, the price, as well as a spot on the bottom where the client will give us a deposit and a signature. This is Ace's file. It contains his permanent medical records. The front is his signalment sheet and a summary of his vaccines and exams that he has come in for previously. Behind it are the doctor's notes and technician notes. He's a pretty new client, so we've only seen him a few times. On the left side are the blood work and any previous medical records. He had gone to a previous hospital before us. This is the blood work which we performed a few days prior to the neuter. It includes a chemistry, a complete blood count, and we do require coags for these types of surgeries. Behind that are the previous medical records from his old hospital. And this is the welcome sheet that they fill out when they first arrive. If we needed to perform any additional lab work on Ace to send out to the lab, we have a few different labs we use. That's IDEX as well as Antec. These lab forms are filled out with the patient's name as well as any tests that the doctor would like. This is our pathology and the cytology form for Antec. But we did not need to do any additional blood work on or diagnostics on Ace. To ensure that the correct procedure is done on the correct patient, we have a few different ID tags, such as the cage card, which goes on the front of the cage on a clipboard, has the patient's name, the surgery to be performed, the doctor, and some treatment information that we had filled out after the neuter. Another ID tag we have is the paper collar, which adheres around their neck. It has his name and signalment information as well as the doctor performing the surgery. There's also a whiteboard in the back that details the patients that are currently in the hospital and any treatment they might need. This is our surgery report. It's already filled out, as you can see, since we did already perform the neuter. Up top we have our patient's information, the physical exam findings, the pre anesthetic medications and information, as well as some post-op medications. We have our doctor's notes here at the bottom and her signature. And on the back side, the technician fills out the monitoring information. And further down we have our recovery information, our pain scores, and signatures from both the doctor and the technician. Our discharge instructions, we have a variety of different pages we send home with the owner, but we also like to schedule aside a time that we can discuss any questions or concerns they might have. This is our basic neuter discharge instructions. It gives a brief summary of the neuter and the aftercare, which we verbally go over with the owner, but we also send home this written instructions in case they forget anything. We make sure we go over the food and water because they do receive a smaller meal that night of anesthesia. Make sure to tell them to check the incision daily. Try to restrict their activity as best as they can. Give any appropriate medications that they might receive. For many surgical procedures, we send home an Elizabethan collar, so we make sure to show the owner how that comes on and off. And then the doctor can fill out any other comments she would like to write at this bottom part here. We get the signature of the owner and keep a copy in the permanent medical record. I'll be demonstrating how to get a patient in and out of the cage. I have a slip leash ready to go. Whenever you're approaching a cage to get an animal out, you'll want to make sure to approach in a non-threatening manner and use a reassuring voice to get them out of the cage. So this is Toby. Hi, Toby. I have my slip leash ready to loop around his neck. Just like that. There you go. And to put a patient back in the cage, you'll want to lead him back in gently. Come on. Come on, Toby. Come on. Toby. Come on, in the cage. Come on, buddy. Just like that. And then you can gently slip the leash off. And shut the cage. For cats, you can have a towel handy to just kind of scoop them up if they're smaller and in a smaller cage. But the same technique, using a reassuring voice and making sure not to approach so that they feel cornered. I'll be demonstrating how to hold off for blood draws. The way you hold off depends on which area that they're drawing blood from. So for example, for the cephalic vein, you'll want to hold around the neck with one arm, and then with your other arm, you'll want to hold behind the elbow, apply pressure, and roll with your thumb, and that way you're distending the vein. And when the blood draw is finished, you can apply pressure to the spot until it clots. For a jugular vein puncture, you'll want to extend the head and neck upwards. It's okay, sweetie. And that way the blood draw can access the jugular vein. For the lateral saphenous vein, it's ideal that the patient's lying down. And what you're going to want to do is apply pressure to the thigh here, and that will distend the vein down here, and the blood drawer can go ahead and get the sample. I'll be showing how to properly put a muzzle on a patient. I have my proper size muzzle ready with the strap adjusted so I can tighten. It's important if you're dealing with an aggressive dog to have someone holding so you can focus on putting the muzzle on safely. The top of the cone goes on the top of the nose, like so. And it straps behind the head, and then you'll want to tighten. Make sure that the muzzle fits snugly so they can't bite, but gives them enough room to pant if needed so you can observe their color. I'll be be demonstrating the physical exam. It's always important to do a physical exam on the patient the day of surgery. So a good way to approach this is to start from head to tail, make sure I don't miss anything. So first, I'm going to overall assess his mentation, his body condition. He has a healthy coat. He's at a healthy weight. I can palpate his ribs easily. He's got a nice weight. He's bright, alert, and responsive. Now I can check his eyes. So first I'll observe for any redness, swelling, discharge, anything like that. Everything looks good. I'll use my ophthalmoscope here. Looks good. Now I'll assess his ears with including the external pinnae, and then I'll use my otoscope to see down into the canal and the eardrum. I don't see any debris or redness. Looks good. Again, I'll use my otoscope to look down the canal and visualize the eardrum. Just some mild wax, but other than that, that ear looks good. Since we're performing a dental today, it's important to check the mouth. He has some mild to moderate tartar buildup. We're missing a canine on the left side. He's got an overbite, which is why his tongue hangs out, and his jaw's a little bit crooked, but that's nothing new. This side looks good. His gums are a nice healthy pink color, and his capillary refill time is about less than 2 seconds. Next, I'll move down to feel his lymph nodes, his mandibular lymph nodes, his prescapular lymph nodes. I don't feel any swelling or firmness. Next, I will sculpt the heart and lungs, get a respiratory rate, a heart rate, and check the pulse as well. I don't hear any abnormal crackling or wheezing sounds. Lung sounds normal, and our respiration rate is normal, about 20 breaths per minute. Now I will listen to his heart rate and rhythm while simultaneously checking the pulse. I don't hear any abnormal rhythms. The heart rate is a normal 100 beats per minute, and the pulse is strong and has good quality. So next I can palpate the abdomen, so this will let me assess any uncomfortable. If he's uncomfortable, I can assess certain organ systems. So I'll use both hands to gently palpate. There's no pain. Everything feels normal. Okay, and now I'm at the tail end. I can go ahead and get a temperature with my rectal thermometer. And while I'm getting a temperature, I can go ahead and just assess his rectal region just for any abnormalities. I know, buddy. Temperature is normal, 100.7. Everything else looks clear back there, and our physical exam is complete. If there were any abnormalities or anything I found, of course I would report it to the veterinarian. After performing Gus's exam before his surgery, the doctor and I determined that he is a ASA grade 1 out of 5. He's a healthy individual with no underlying diseases and just has the mild tartar buildup, which is why we're doing the dental. I'll be demonstrating how to draw blood from the cephalic vein of Chester the cat. So spraying down my area. Have a 25 gauge syringe here, or 25 gauge needle attached to a syringe. My bevel's up. I'll be demonstrating how to draw blood from the cephalic vein. This is Toby. So I'm going to spray down my area. I have my 22 gauge needle attached to my syringe. I'll want to make sure that my bevel is up, facing upwards. It's okay, sweetie. And then go ahead and pull back. I'll be demonstrating how to get a blood sample from the jugular vein of a cat. My holder has the neck extended upwards and the legs pulled downwards. My area is sprayed down with alcohol. Just going to this here and pull back the syringe. I will be demonstrating how to draw blood from the jugular vein of a dog. So we spray down the area. Go ahead and pull back my syringe. And that's it. I will be demonstrating how to get a blood sample from Toby's lateral saphenous vein. So I have my area already sprayed down with alcohol. It's okay, Toby. I'm using a butterfly here. Look at my needle here. And that's it. There are several minimum databases required on the pre-op blood work. They include the PCV, or the packed cell volume, the total protein, the BUN, or blood urea nitrogen, and the alanine aminotransferase. The PCV, or the hematocrit, is the percentage of whole blood made up of red blood cells. High percentages can indicate dehydration, and low percentages can indicate blood loss or decreased red blood cell production. Any percentages that don't fall within the normal range should be brought to the VIC's attention immediately. Total protein, or total solids, is an indicator of the patient's plasma protein levels. Major plasma proteins include fibrinogen, albumin, and globulin. These levels are an indicator of serum oncotic pressure. The BUN, or blood urea nitrogen, is an indicator of kidney function. It indicates the kidney's ability to remove certain nitrogenous waste, such as urea, from the blood. So high levels of BUN can indicate that the kidneys may not be working properly. The ALT is an enzyme found in the liver of dogs and cats. So levels of ALT can be used as a general hepatic screen. For example, if there are high levels of ALT, that can mean damage to the hepatocytes. Those are the main databases for the pre-op blood work. Additional databases may be required if there are abnormalities on the blood work or the physical exam. For example, if there is pain upon palpation of the abdomen, or the patient is having vomiting, there may be reason to take x-rays. If there is an abnormal heart rhythm or murmur that was not there previously, an EKG may be of value. Another example is if the patient is having diarrhea, a fecal sample may be sent out to the lab to diagnose possible intestinal parasites. For geriatric patients, typically a full blood panel is required, including a chemistry to assess organ function as well as a complete blood count. If a patient is exhibiting a urinary tract infection, a urinalysis may be required to check certain details of the urine, and many other additional diagnostics can be performed. You will always want to consult with the veterinarian before performing additional diagnostics. For a patient's pre-anesthetic protocol, the veterinarian always determines what medications he or she will be given. It depends on the patient's health status as well as their previous health issues or history and their age. For this example, I will be giving an appropriate pre, peri, and post-anesthetic protocol for the neuter that we performed a few days ago and that I demonstrated during check-in for a Spot, the 11-month-old husky. He is a healthy male with no previous health issues. For the pre-medication of ACE, Dr. Reitz would give an injection of 2 meds. The first is a morphine derivative called hydromorphone. The second is a Valium derivative called midazolam. These injections would be given intramuscularly. Once ACE is calm enough, we would place an IV catheter and begin induction. Induction would be used with propofol that would be given through his IV catheter. Once an endotracheal tube is placed, he would be hooked up to the isoflurane gas, and that would be his maintenance for the duration of the neuter. Upon clipping and prepping for the neuter, Dr. Reitz would be giving an injection of bupivacaine in the scrotal region. This would just be an added pain management so that the gas wouldn't have to be on such a high level. When he's in surgery, we would perform the neuter, and after it's finished, an injection of non-steroidal anti-inflammatory would be given. Usually we use Medicam. For go-home meds, Medicam would also be used in the oral version, but we would advise the owner that the NSAID Medicam would not need to be given until the next day since he has the injection on board. If needed, pain meds would be dispensed such as tramadol or gabapentin, but typically for neuters, we do not send home tramadol or gabapentin. The NSAID is usually sufficient. I will be making an entry into my controlled substance log. I have my surgery sheet, which contains the pre-med, which is butorphanol, the concentration and the amount. My drug log is open to the butorphanol section, which I've confirmed. And then I'm going to write the date, the patient's name, which is Chester, the amount given in mLs, 0.05, and the doctor that administered it. Demonstrating the parts and functions of the anesthesia machine. First, we have our oxygen tanks. These are the larger H tanks that are secured to the wall and strapped. The pressure reducing valve takes the pressure from the tank and reduces it to 45 psi, and then the oxygen travels to the lines. This is our hookup that I have here attached to this anesthesia machine. First we have our oxygen flow meter right here, which is measured in liters per minute. This further reduces the pressure in the system down to 15 psi, which is close to atmospheric pressure and well tolerated by patients. You can control how much oxygen is going through the patient via the flow meter by turning the knob to the desired measurement. Next to the oxygen flow meter, you have the fast flush valve, which can rapidly infuse oxygen into the circuit by pressing. Precision vaporizer is next. We have two here that house different types of gases. The first is the isoflurane, and the second down here is the SIVO. I have my machine hooked up to the isoflurane. The precision vaporizer houses the liquid anesthetic gas that when you turn the knob on, when you turn the vaporizer on, it will become vaporized into a gas and travel with the oxygen to the patient. Next you have your unidirectional inspiratory valve up here, which houses a disc that will flutter whenever the patient inspires, and the gases will travel through the valve down this side of the corrugated Y-piece tubing, this side, and into the patient. This end is hooked up to the endotracheal tube. When the patient expires, it will travel up this side of the Y-piece and into my unidirectional expiratory valve, which works similarly to the inspiratory valve in that it flutters also when the patient exhales. It's a good indicator of the patient breathing. On top of my expiratory valve is my pop-off valve, which is a good valve that can vent the system when it's in an open position to prevent buildup of pressure within the circuit. The only time it should be in a closed position is when you're manually ventilating the patient. It should never be left closed, always left in an open position. That leads me to my reservoir bag here. These come in a few different sizes. This is a 3 liter, but we carry bags up to 5 liters, depending on the size of the patient. The bag allows the patient to breathe in gases that are stored within the bag. When the patient inspires, the bag will deflate, and when the patient exhales, the bag will inflate. This can also be used, like I said, to manually bag the patient, in which you'll want to close your pop-off valve all the way, squeeze your bag to a pressure no higher than 20 centimeters of H2O on the manometer, which I will get to next, and then open up your pop-off valve again. So the manometer measures the pressure within the circuit. It gives you a good indicator of the pressure within the animal's lungs. It's, like I said, measured in centimeters of H2O, and when you're bagging, you never want to exceed the 20 marker right here. Our scavenging system in this practice is passive. We have a canister at the bottom here that relies on gravity to take the heavy anesthetic gases and bring them down into the canister, into the activated charcoal. My exhaust tubing is hooked up to my pop-off valve here. To make sure your scavenging system is working correctly, you'll always want to periodically measure your canister, and when it gets to about 50 grams, you'll want to discard and get a new one. The CO2 canister is here. This is consisted of granules that will absorb the CO2 and they create a reaction together. When the crystals are depleted, they turn a purple color. In that instance, you'll want to replace your crystals, but you never want to wait till it gets that far, you'll always want to have a maintenance schedule with this to replace the crystals. I have my cuff syringe attached to the machine because when we hook up the Y-piece tubing to the endotracheal tube, we'll always want to inflate the cuff, and so I have a syringe ready on the machine for that purpose. In the previous video, I had hooked up the rebreathing circuit, but in this portion I have my non-rebreathing tubing hooked up. This is a good circuit that can be used for patients that are small and weighing less than 7 kilograms because there's low gas resistance, but you do need a higher oxygen flow rate to deliver the anesthetic. So I have my oxygen hooked up to the vaporizer, and then on my outlet port is my non-rebreathing tubing, which will have this end hooked up to the endotracheal tube. A bag is attached here, and then my waste will again go into my passive scavenging system of my activated charcoal canister, which, as I showed before, is attached to the anesthesia machine, but it is off the ground so that it can be ventilated. I'm going to be demonstrating how to perform a leak test on the anesthesia machine. I have my rebreathing circuit hooked up, and first thing I'm going to do is close my pop-off valve. Now I'm going to plug the other end of my Y-piece tubing with my hand. Make sure no oxygen will escape from either end of the circuit. I'm going to use the fast flush valve to quickly infuse oxygen into my bag and see if my needle on the manometer starts to descend. I'm going to inflate the bag till I get to the 40 centimeters H2O and watch my needle from there. Okay. I'll look at the clock for about 20 seconds and make sure my needle is not going below 40. As you can see, it's staying just right above 40 there, right at 40. What I can do as well to check any leaks in my flow meter is I can turn my oxygen onto 0.2 liters per minute, make sure my needle is not descending. Wait a couple more seconds. If there was a leak, my needle would be moving down towards the 0, and I would have to check each component of the circuit to figure out where the leak is. We look good, so I'm going to go ahead and open my pop-off valve. Now my bag will deflate and my needle will go back to 0 because I'm releasing the oxygen. Here I have my supplies needed for the induction of anesthesia. I have my anesthesia machine with proper tubes selected. It's a small 10-kilogram dog, so I have my small tube set up, hooked up to my isoflurane. I have a tie that I'm going to be securing to the endotracheal tube and tying it to the patient to hold it in place. I have 3 sizes of endotracheal tubes. The patient, like I said, is 10 kilograms, so I've chosen a size 7, 7.5, and an 8, just in case we need to go up a size or down a size. I have my syringe to inflate the cuff on the endotracheal tube, so that just creates a seal so that the patient doesn't aspirate while under anesthesia. I have a gauze sponge with some sterile lubricant to lubricate the tip of my endotracheal tube. I also have another piece of gauze so that the tongue can be held as the patient's being intubated. I have my laryngoscope, which has a light on the end so they can visualize the trachea. and that's all my supplies. I will be showing how to place an IV catheter in the cephalic vein. So first I'm going to shave the area. Scrub with the chlorhexidine. Have my 24 gauge catheter. Secure the IV cap. Now I can start taping. First piece is the anchor piece. Wrap that around. The next piece. Making some tabs so that it's easier to come off. I'm going to tighten my cap. Put on my last piece. Now to make sure the catheter is in, I have a flush. I'm going to go ahead and flush the catheter. Now if the catheter was not in, you would see kind of a bubble of fluid under the skin, and that would indicate it's not in the vein. So here's my flush here. Go ahead and flush it. So I don't see any bubbles, and I actually can feel the flush going through the vein. And now I just want to bandage catheter here. And it's ready to be hooked up to fluids. How to place a catheter in the lateral saphenous vein. So first I'll shave the leg where I'm going to place the catheter. Sorry, Jen.
Okay.
Okay. Now I'll scrub the area with chlorhexidine scrub. Making sure to get these hairs out of the way. Okay. Now I have two size catheters just in case, a 22 and a 24, my injection cap, which I'll have ready. A 24 gauge catheter.
Oof. Okay. It's okay.
Have my bevel up, my holders occluding the vein. Go ahead and See that I have flashback, so I can go ahead and advance the catheter. Okay. Put my injection cap on. Go ahead and wipe this extra blood here. Clean that up later. And then I have my pieces of tape here. So the first piece is the anchoring piece, which will wrap around. I know, sweetie. And then we'll go around the leg here.
It's okay, it's okay.
It's okay. Oh, I know, sweetie.
We're almost done, baby.
Okay, my second piece of tape.
You're fine.
Okay. Sometimes it's nice to do tabs so you can easily remove the catheter. And my last piece of tape. Okay. And now to check to make sure that the catheter is in, we'll go ahead and flush. So I'll want to make sure that my flush is not bubbling up here to make sure that it's inside of the vein. So we'll go ahead and flush. And my holder can feel it going through, as well as I don't see a bubble making it so that the catheter would not be inside of the vein. So we'll go ahead and flush to make sure it's patent. And then I can go ahead and bandage the catheter with my red bandage.
Perfect.
Like so. And that's my catheter. We're ready for induction. My fellow technician is pre-oxygenating the patient. We will want to do this for 5 minutes. While this is going on, I'm going to be explaining how we measured the endotracheal tube. This is a size 7 based on Snoop Dogg's weight. We pulled a size 7 as well as a few sizes up and down, a size 8 and a size 7.5. What we do is we measure the tube halfway between the thoracic inlay and the larynx. Then we identify the canine tooth, and the tie is going to go just caudal to that canine tooth. And that's where it will be pre-measured, so when she intubates, that will be the stopping point. And then we'll take the tie and tie it around the nose or the back of the head. To make sure that the cuff is properly inflated, we'll want to pre-measure how much air goes into the cuff. And we've determined that that pre-measured amount is about 13 ml, so I'll go ahead and inflate 10, and then I'll inflate an additional 3. And that way my cuff is properly inflated so that it's providing an adequate seal. Go ahead and deflate that so it's ready. I have our induction agent. We'll be using propofol today. It's a fast-acting induction agent, and we will be giving this titrating to effect so that he will be ready to intubate. This will be given through his IV catheter, which is in this leg, and that should get us ready for intubation. I have my piece of gauze that is lubricated with sterile lube so that we can lubricate the tip of the endotracheal tube for easier passage. And we're going to go ahead and start giving the propofol while I'm holding the mask. Just going to slowly give it just until he's ready. Now I'm going to be holding him, his mouth open, She's going to be using her laryngoscope to visualize the trachea and passing the tube to the pre-measured amount. Okay. Now we're going to be connecting our patient to oxygen. Inflating the cuff and tying it in. So I'll measure 13 mLs. And we will tie around the back. And of course, any surgical patient, we will want to place some eye lubricant to protect their eyes since they don't close them. So go ahead and do that. And we're ready for clipping and prep. I'll be demonstrating how to give an injection via sub-Q. This is Medicam. So what I'm going to do is make sure my bevel is facing upwards. Grab the tuft of skin, pull back on my needle, make sure I'm not in a blood vessel, there's no blood, and then go ahead and give it. I'm going to be demonstrating giving an IM injection. This is Gus's pre-med. So I'm going to go right into the muscle. I want to aspirate and make sure I'm not hitting a blood vessel, and then slowly give it. I'll be demonstrating how to give an injection IV. This is just saline, so I'm going to be using the medial vein back here. Go ahead and insert, and I'm going to pull back my hub to see that there's blood. My holder is going to lift up her hand, and I'm going to go ahead and give the injection and hold off there. Demonstrating surgical prep for a spay. So I'm going to begin my pre-surgical clip and scrub out here on the wet table. When holding the blade, I'll hold it as flat as I can to the chest to get a close shave. Sorry, Maddie. I can pull the skin taut with my other hand to allow better shave. I want to make sure to get at least 2 blade lengths over from where the incision will be on the abdomen here. And my 40 blade will allow the closest shave possible. quickly just grab a pair of gloves. You can just... Now I can start this pre-scrub. So since we're going to do an additional scrub inside of surgery, I am just going to do the chlorhexidine. So first, to eliminate any extra hair, I'm going to lint roll.
Done?
Yeah, do you want to check this? See if I need to shave anymore?
It's fine.
Just get a little bit more. Okay. Dr. Handel's just going to be local blocking the area. Is that good? Blocking more? A new pair of gloves for my scrub. This is chlorhexidine. So we'll start from the middle and do a spiral pattern outwards. This will also help to eliminate any more hair. 3 times. Okay. I'm using a scrub that we only use for surgery, as well as clippers that we only use for surgery, just to reduce contamination. I go ahead and remove my gloves, take my jacket off, which may have collected any hair, and use the towel to carry her into surgery. My helper, as soon as she's finished her monitoring, she's going to help me unhook her.
Actually, can we do
You
a
wanna
temp on
grab
her
a-
real quick?
Sure. You want to grab a new towel as well. Can you give me a towel? So I'm just going to scoop her with this. So now I'm going to carry her via my towel into surgery. Hopefully the lights turn on. There we go. I'm going to put her on the table. Take my transport towel out. We're going to secure her to the table with 2 half-hitch loops here. Like so. And then wrap her around securely. Hold tight. Drag her back legs in. Same way. Okay. Now my assistant has her hooked back up to the machine. We'll be applying the EKG monitor. Okay. Just gonna grab a cap and mask. I'll do my final scrub. Since we are using the laser, I'm first going to be scrubbing with chlorhexidine and rinsing with the saline agent because alcohol would be flammable to the laser. Okay. Same type of technique where you do 3 times in a spiral pattern. Out from the surgery where he will be making the surgical incision. Making sure not to touch the middle area after you've already scrubbed it. So, take my rinse, saline. That'll just go ahead and remove the detergent, chlorhexidine detergent. Okay, now she's ready. I'll be demonstrating how to perform CPR if my patient were to go into cardiac arrest. When performing CPR, the mnemonic device used to be the ABCs, which stands for airway, breathing, circulation, but more recent evidence has suggested that circulation is the most important thing to establish right away, changing it to CAB. So to address circulation, you will want to have your patient lying in lateral recumbency. So depending on the size of the dog is going to determine how exactly you'll do your chest compressions. So for my smaller dog patient here, I'll be using one hand to do my chest compressions. This works with small dogs and cats. So what I will do is take my hand, I want to come a little closer here, take my hand, my thumb and the rest of my fingers and go ahead and make my compressions just like that. For the small cats and dogs, I'll want to be applying the compressions directly over the heart, and the compressions will be about 30% of the chest wall. Be compressing it by about 30%. Making sure before I start my next compression to let the chest rise back up again. With small dogs, they have higher heart rates, so you'll want to do about 100 to 120 compressions per minute. With larger dogs, you'll do a different method of chest compressions where you'll use the heel of your hand, again compressing the thoracic wall by 30% and letting the chest rise up again before you start your next one. For larger dogs, you don't have to do as many compressions, probably about between 80 and 100. Now with larger dogs, the point on the chest where you'll be doing your compressions is the area where the chest is the widest. So one way you can do that is take your patient's arm, push back so that the elbow hits the chest, and that would be the point of where you would be doing your compressions. It's important to have a few team members on your CPR team. That way you can alternate chest compressions if you get tired. To check the effectiveness of your chest compressions, you'll want to periodically check the pulse. You can check the femoral pulse back here. The next important aspect of CPR is the airway and breathing. So another team member can check the airway. You'll make sure not to stop your chest compressions, so it's good to have another team member perform this task. So you check the airway, the mouth, for any obstructions, any vomit, blood, a foreign object. If it's all clear, the ideal situation is to intubate with an endotracheal tube, and that way you're maintaining an open airway. So once the patient is intubated, you can hook the endotracheal up either to the anesthesia machine which would provide 100% oxygen, or you can hook the endotracheal tube up to an ambu bag. The only disadvantage to most ambu bags is they only can deliver 21% oxygen. So with the airway and breathing, once they're intubated and they're hooked up to an oxygen source and you're manually giving them breaths, you'll want to give about 8 to 12 breaths per minute while another teammate is giving chest compressions. Another option is that the doctor can give drugs to help aid in the recovery process. Drugs such as epinephrine, atropine, vasopressin can be administered by the veterinarian. If the patient regains a return of spontaneous circulation, the patient should be closely monitored over the next 12 to 24 hours with the EKG, a blood pressure, the pulse ox, just because a lot of times patients can go back into cardiac arrest after an episode, so careful monitoring is absolutely necessary. The pulse oximeter, it's an important piece of equipment that can oftentimes determine the stability of the patient. It utilizes a probe with a red light in the middle to determine the saturation of hemoglobin, and then the machine calculates the patient's oxygen saturation by calculating the differences in levels of oxygenated and deoxygenated hemoglobin. These levels are calculated based on the light's ability to absorb the two. The probe is oftentimes attached to the patient's tongue or the pinna of the ear. It can also be placed on the prepuce or the vulva. The percentage value shows up in blue right here on our EKG machine. Percentages in patients should be above 95%. If percentages fall to 90, this should be investigated with supplemental oxygen therapy and notifying the veterinarian. And any percentage that's 85% and below should, for more than 30 seconds, should be a medical emergency and it should be evaluated ASAP. Demonstrating the esophageal stethoscope. So I have a picture here. The esophageal stethoscope consists of a thin rubber tube that is lubricated and placed down the patient's esophagus. The rubber tube is then hooked up either to a conventional stethoscope or an audio monitor where the heart sounds can be listened to. The benefit of the audio monitor is that if in the surgical suite, the veterinarian as well as the technician can both hear the heart sounds. This is our electrocardiograph or EKG. It's a very important piece of equipment that gives us a definitive identification of the heart rhythm. It measures the electrical activity of the heart as it moves through the conduction system. It's an important tool for patients that are under anesthesia, as anesthetized patients can develop cardiac arrhythmias. So the EKG utilizes electrodes to conduct electricity. The two electrodes that go on the front of the patient are the black and white. So the right electrode gets hooked up to the patient's right forelimb and the black gets hooked up to the left forelimb, and they should be both placed proximal to the elbows. The electrodes on the back forelimbs of the animal, the red goes on the left and the green would go on the right. I don't have a green electrode. They should be, once placed on the patient, they should be wetted with saline or alcohol to allow conduction. And the EKG reading would show up on the screen here as a graph, and the tracing could be printed out on a 25 millimeter per second or 50 millimeter per second paper speed with a 10 millimeter per millibole of calibration. Our EKG is also set up to record the heart rate right here, as well as the SpO2. When monitoring the patient's respiratory rate, there are a couple pieces of equipment that can be valuable. Apnea monitors are hooked up to the patient and they produce an audible beep whenever the patient takes a breath. Capnometers are another piece of equipment that can be valuable. They consist of a monitor here that displays several parameters, as well as the sensor and hook up to the patient's endotracheal tube. So the capnometer measures the amount of CO2 when the patient breathes in and out. And so this can be a valuable piece of equipment, especially when evaluating the patient's quality of breaths. So in this side stream capnometer, this sensor is actually located within the machine. On the mainstream capnometers, the sensor is actually hooked up directly between the patient's breathing circuit and the endotracheal tube. So as the patient inhales and exhales, readings show up on the capnometer. This one shows a respiratory rate in beats per minute right here, and then it also displays the end tidal CO2 in millimeters of mercury, which is right here. And normal end tidal CO2s are between 35 and 45 millimeters of mercury. This particular capnograph also displays the heart rate as well as the SpO2. Blood pressure is another very important piece of equipment. Blood pressure can be monitored in a patient directly or indirectly. Direct blood pressure monitoring involves catheterizing an artery and hooking up that catheter to a transducer. So I'll be talking more about indirect blood pressure monitoring. So that can be done with a Doppler that I have here. My Doppler has a crystal on the end. I also have my cuff, which will be placed around the patient's extremity, and the cuff is hooked up to the sphygmomanometer. So what you do first is place the cuff around your patient. So when you're selecting a cuff size, you'll want to make sure that the width of the cuff is approximately 40% of the circumference of the limb that you're putting it on. So that velcros around the patient's extremity. And then the Doppler crystal is applied to a peripheral artery with a good amount of ultrasound gel. So the arteries that the crystal is commonly placed on is the median palmar artery or the dorsal pedal artery. Once you place your crystal on the artery, you'll hear an audible pulse signal coming from your Doppler speaker here. And once you get that signal, you'll start to inflate your cuff with your rubber bulb on the sphygmomanometer. When you inflate your cuff, after a certain amount of inflation, the cuff will compress the artery and you will no longer hear the pulse sound on your Doppler speaker. At that point, while looking at your manometer, you will gently release pressure and slowly as your cuff deflates and the pulse signal returns on the speaker. And what you'll do is you'll see where your needle lands on your manometer, and that numeric value will be your systolic blood pressure. Monitor, as you can see, I've been keeping a log here with the time, recording every couple of minutes. So I'll be writing the time here, 12:35, observing the mucous membrane color. If you want to come up. Yep. And so she's nice and pink. I'll press on it and see that the capillary refill time is less than 2 seconds, which is great. I'm writing that her mucous membranes are nice and pink. And now I will check my EKG for the SpO2, which is here, right here in blue. It's at 96. So I'll record that right there. I'm gonna go ahead and listen for the heart rate with my stethoscope. So I got 25, so I'm going to multiply that by 4 since I counted for 15 seconds to get 100 beats per minute. So right there. Now there's a couple ways that I can count the breaths. I can look at my reservoir bag here. I can also listen with my stethoscope. I can watch her chest rise and fall. So I'm going to go ahead and do that for 15 seconds. Okay, so I got 3, and I'm going to multiply that by 4 again to get 12. Now if you want to come around and I'll just show, yeah, if you just want to stand right where Maddie is. So since we're finishing up the procedure, the next thing on my monitoring sheet is my gas level. So since we're just about finished, I'm going to go ahead and turn her down to 0.5, and that's on my ISO. Now the last 2 things we're going to do is get a temperature and a blood pressure. So we'll go ahead and we have our blood pressure cuff on her here. So I'm going to go ahead and let that run. While that's running, we go ahead and get a temperature. And we just want to make sure it's not too low, otherwise we'd have to put the bear hugger on her. Go ahead and get a temperature on her. While my blood pressure is running here. Now always just want to be vigilant when they're in surgery, that she's breathing normally. It's a good idea. Now her temperature is about 97. So we'll just want to make sure that her heat is on in the cage so that she can recover nicely. So I'll write that down on my sheet under temperature, 97. And my blood pressure is 100, so I'm going to go ahead and write that on my list, and those are all my parameters. I'll be demonstrating how to scrub in as a sterile technician. I have my cap and mask on already. All my jewelry is removed. So first I'm going to open my pack so it's ready to go after I scrub. And my gloves.
Yeah, that's fine. I'll figure it out. Oh.
Before I begin scrubbing, I'm going to be demonstrating a hand wash. Going down to my elbows, getting all sides. Okay. Next, with my nail pick, I'm going to clean my nails.
So what we can do, we can try it out of the
Now with my pre-loaded scrub brush, it has chlorhexidine already inside. I'm going to go ahead and scrub the fingertips 10 times. And then move to the surfaces of my hands, starting with my thumb. 10 times on each surface. Making sure to get in between the fingers.
up and I think, I mean, probably not really bad.
No, just kidding. We're leaving.
But you probably realize early.
I'm moving to my hand and my palm.
Oh.
No, it's fine. I just walk over and I just
And down to my arm, 4 sides. Down to my elbow. Now I can move over to my other hand, starting again with my fingertips. My hand. To my arm and elbow. Okay, now I can rinse. So when I'm rinsing, I want to make sure to let the water run down my elbows, not to touch anything. Okay, now I'll grab my sterile towel in my gown and towel pack, open it up here, and begin drying my hand. Down the other side with my other hand. I can grab my gown. Go ahead and open it at the neckline here. Okay. Maddie has just tied me in and turned the water off so you can hear better. My hands are contained inside the gown. And I'm going to grab one glove by the edge here. Pull it around the cuff like so. Now with the other one, go ahead and open it, slide my hand in. And when I go through into surgery, I'll make sure to keep my hands above my waist, and I can go ahead and begin assisting the surgeon. Now I will be draping the patient. So I have a pre-fenestrated drape. Towel clamps. Okay. And now I'm going to be laying out the instruments for the doctor. So I have my scissors, blade holders, I won't need the spade hook. Hemostats. I have Alice tissue forceps. Bar melts. We'll be using a surgical laser. I have that ready. My forceps, rat tooth and regular, needle holder, and my blade, which I will load, and gauze. The needle drives.
And then a pair of the curved hemostats, the small ones. Thank you.
To maintain sterility, I'm keeping my arms above my waist, making sure to assist her in any way she needs to.
Another pair of the jean specs, please. And have the scalpel, please. Thank you. And then we'd be prepared to blot.
I'm going to be blotting.
The forceps, please.
Forceps, there you go.
Thank you.
Duties of the sterile surgical technician include passing the surgeon instruments in the appropriate manner. It includes setting up the sterile surgical field, which can include draping the patient, setting out the pack in an organized fashion so that the doctor can access instruments easily, passing the doctor instruments in the appropriate manner, as well as blotting any excess bleeding with the gauze sponges, keeping exposed tissues moist either with lap sponges or with sterile saline. In order to maintain asepsis of the surgical suite, when the surgical technician is gowned up and sterile, you'll always want to make sure you keep your hands above your waist as the sterile field on you is from below your shoulders to your waist or where the table rests. You want to make sure to either clasp your hands, hold them out, or you can rest them on the sterile drape. You'll never want to cross your arms as your armpits are not sterile. The back of you is also not sterile, so you never want to turn away from the surgical field. If you need to cough or talk, that should be done away from the surgical field so that any debris might be passed away instead of towards the surgical field. If either the circulating nurse or the sterile technician notices a break or in the sterility, will want to take measures right away to fix it. For example, if becomes a hole in someone's glove, that would be to remove the glove and sterilely replace it. It's also important that the circulating nurse only touches non-sterile items, and the surgeon as well as the sterile surgical technician only touch sterile materials. Properly clean up the surgical suite. So the first thing I want to do is go ahead and take out my towels and my surgery laundry. The towels get laundered, but the surgery goes in a special hamper just designed for laundering the surgery gowns, towels, drapes, things like that. So make sure I don't have any sharps or anything. I've already separated the sharps out.
Actually, I think the binder is probably
So these go in my surgery laundry. The instruments I will be putting in my sink basin to pre-soak. That way the pre-soak will get off any dried up blood or debris that are on the instruments. So I'll set those over here. Okay. Now I'll want to make sure to properly dispose of my sharps in the red hazardous sharps bin. So I have a blade and 2 sutures here that we'll carefully pick up and dispose of. Now I can begin putting the materials away, including the water blanket, wrapping that up. Basically the idea is to clear the room so that I can do a spray down and a mop as well. So we will move aside the mayo stand, throw away anything that can go in the trash can, disassemble my surgical laser here. This up. Okay, this goes with my instruments to soak. Now my anesthesia machine, unhook it from the oxygen source. Since we are finished the surgeries for today,
Hey, so did we decide
wrap up
which
my
one you wanted
tubes.
to- I think it's kind of tough because you don't tell people you're charging for something, you know.
Put them away. Can wrap up my EKG machine with all the cords.
So now they gotta drill somewhere. Okay.
Now I can begin wiping down the surgery table. Make sure my oxygen's off, my gas is off. Can begin wiping down the surgery table. I have a kennel solvent that's used just in this room just to minimize contamination. Down for now. So you want to make sure you wipe down all surfaces of the table just to minimize any dust buildup or anything like that. I also want to wipe down the light source. collect dust. Spray down my nail stand as well, since that's where the surgery pack was sitting. Okay. Now I can throw that for the dirty laundry. I have a fluid bag here that I can go ahead and clean up. Make sure it's locked so it doesn't leak everywhere. Put this aside. I'm going to move my water blanket so I can start sweeping the floor. So sweeping just will get off any sutures that may have fallen, or any kind of dirt or debris that may have been brought in. It's important to minimize the traffic in the surgery suite. So once we're finished, make sure to shut the door and the windows to make sure nothing can get in. Roll these out. Now I can start, I'll take the trash out. This contains, you know, materials such as paper wraps and things like that that we disposed of. Now I can mop. Now it's important to use a mop that is only designed for the surgery room, again, to minimize contamination. Start from the back and make my way to the front. It's important to clean surgery daily, even if you're not using it, because again, you just want to make sure it's as clean as possible. So now that I've mopped, like I said, I'm gonna take my materials, the laundry and garbage, take it out, let the floor dry, and load my material, anything that needs to go back into its place. Shut the door, close the window, just make sure that nothing else can get in, just making it as sterile as possible. I will be demonstrating how to properly clean instruments. This is a pack that we just finished using. I had it sitting in distilled water in my sink basin, and that's just kind of a pre-soak to get off any dried blood, debris that could have collected on the instruments. So now that they've been sitting in the pre-soak for about 10 minutes, I'm going to go ahead and use a soft bristled brush. It's really important not to use a wire brush, because you could cause damage to the instruments. And I want to make sure and just give a good scrub across every surface of the instrument, including the interior, these bristles on this on these forceps here. With the hinged instruments, you want to make sure to scrub the box lock, the shaft, and the handles as well. Just give all your instruments a good scrub. Now, it's helped that these have been sitting in the pre-scrub because there's not a whole lot of debris on here. These are my needle drivers. Scrubbing all parts. Now, once these are finished scrubbing, I'm going to load them into the ultrasonic cleaner. The ultrasonic cleaner uses sound waves to produce tiny bubbles that will produce a scrubbing effect on the instruments. The ultrasonic cleaner is very good for these hinged instruments that need those bubbles to get in between the box lock and the handles and the grooves. These are my Alice tissues. So now that my instruments have been scrubbed, I didn't show the whole pack just because it's a pretty large pack, but I scrubbed and rinsed with my distilled water. Now I can begin loading them into my ultrasonic cleaner, which, like I said, utilizes tiny bubbles as a kind of a scrubbing motion. It's called cavitation. So when I'm loading my instruments in here, I want to make sure that the hinged instruments are opened. That way the bubbles can work their way into the grooves. The enzymatic cleaner that's in here is mixed with distilled water per the instructions on the bottle. Give that 1 second. Once these are loaded, I don't want to load it too heavily because I want to make sure that that there's enough room for the bubbles to go ahead and clean around each instrument. So I might do 2 loads. Okay. Now put the lid on, and this, per the instructions on the bottle, runs for about 10 minutes. So I'll go ahead and set my timer. 10 minutes, and that will run, and I will take them out when they're finished. Now that my timer went off, I can go ahead and remove my instruments from the ultrasonic cleaner. Now, before placing them in my lubricant bath, I'll just go ahead and rinse them in some distilled water, and that'll just get off any mineral deposits or anything left over. And once, give them a quick rinse, I can go ahead and load them in the lubricant bath. The lubricant bath is mixed with, it's just a couple splashes of lubricant, instrument lubricant, which is that kind of white milky color, as well as the some distilled water. And same deal, I want to make sure that my instruments are open when I'm loading them in. And the lubricant bath just prevents any rust from building onto the instruments and prevents corrosion, so this is an important step. And we typically let these soak for 5 to 8 minutes. And once it's finished, we'll lay them out to dry. And once they're dry, we can go ahead and wrap them up in a pack. Properly wrap a surgical pack. This is our orange general surgery pack. So it's already, my instruments have already gone through the cleaning process, the ultrasonic cleaner, the lubricant bath, they've dried, and they're ready to be assembled in the pack. So I have a checklist which I'm going to be checking off just to make sure I have all my instruments. So first, we're going to start off with my car malts. I have 3 large car malts. I'm gonna make sure that the box locks are not fully locked whenever we're wrapping the pack here. So we'll just make sure. So I have my 3 large curved car malts, 2 medium curved car malts, which go back here. Now I'm going to have them on my loop so that on the loop of my finger so that I can nicely lay them out, and the surgeon can go ahead and pick out whichever instruments he or she wants. So my 2 Alice tissue forceps right here, 2 straight hemostats, which are right here. Again, I'm just making sure my box locks are not locked. Okay. 2 small curved hemostats. Okay. 2 small straight hemostats. I have a needle driver here. And then 2 pairs of scissors, the Metzenbaum and the Mayo dissecting scissors. Now, like I said, in order to lay these out nicely, I'll loop through this bay hook, like so. Lay them out like that. Okay. Next are my gauze sponges. Now, we always count out how many gauze sponges we have in the pack. That way, in surgery, we can make sure that none are left inside of the animal, or just so we can keep track. So I have 2 sets of 5 here. I'm going to lay them on top. Next, I have the rest of my instruments, which is the blade holder, 2 types of forceps. I have the rat tooth and the regular thumb forceps, as well as my towel clamps. Now I have 4 towel clamps. Again, the box locks are not locked, and these are going to go on top here, because when the surgeon is setting up their drape, that's the first thing that they're going to want to grab. So you want to kind of set up the pack according to how they would like things done. Now I have my surgical drape. This is a pre-fenestrated drape. It's folded accordion style, which I will show later on. So we'll stack this on top of everything, because again, this is going to be the first thing that they lay out onto the patient. A sterilization strip, which after going through the autoclave, it will have the rest of this filled out in black saying, okay, it has been sterilized. Now for our general surgery packs, we wrap 2 times in two drapes. So my first drape here, I'm going to open it up, have it set down like a diamond here, put my pack in the middle. Now we're going to start folding, making tabs here first, and then fold my tab back. Now I can move on to the sides. Again, folding, and I want to make sure that this is tight, snugly wrapped. My last one, tuck it in under itself. And then, like I said, our general packs are double wrapped. That way the circulating nurse can open the first layer and the second layer will be sterile. I'm going to do the same thing as I did with my first one, making my tabs one side at a time. Here, tucking under itself. And now, for identification purposes, put some masking tape on the outside. A little bit longer. a little tab here so this is easily removed. We'll be writing the type of pack, which I said is a general orange, the date, my initials, and lastly we'll put a strip of indicator tape, which, like the strip, after running through the autoclave, will be striped to indicate sterilization, and it's ready for the autoclave. I'll be demonstrating how to fold a drape, which I had put in my pack earlier. This is the pre-fenestrated drape, and the folding method for this is going to be the accordion method, so that way when the doctor opens it up in surgery, it easily falls out without having to shake it. I don't see any hair or lint that has collected after the laundering process, so I'm going to go ahead and start folding. So you'll just fold the drape back onto itself like an accordion. And then the last step will be folding it into thirds so that it can fit nicely in the pack. The gown and towel pack. So this is a gown that I've laid out. It's not inside out so that the doctor can easily place his or her hands in. So what I'm going to do is I folded my arms back here. Just going to make sure I don't see any lint or anything on there, but just do a quick lint roll here. Fold one side halfway inwards. Okay. Now my next side, come inwards as well and meet halfway. Now what I'll do is I'll fold it lengthwise again. Now these strings I'll want to keep out so that the doctor can grab from the neckline as well as the strings. Fold it once more so I have a nice long gown here, and now I can begin the accordion fold so that again the doctor can open it without any issues. Ties are out. Another part of the gown and towel pack is the towel so that they can dry their hands. Fold it in half lengthwise once, and then start the accordion fold again. And that goes on top of the gown. Then you have a sterilization strip, so I'm just going to put it right under the towel so it won't fall. Have a cloth wrap here. The gown and towel pack's just wrapped once. Okay. Put it in the center. Start making my tabs. Okay. Now I can put my sterilization tape, which will have the type of the pack written the date as well as my initials. Tab here. Wrap it around. My indicator tape, sterilization indicator tape here. So, as you can see, it has the size of the gown and towel pack, the date and my initials, and I have my sterilization tape, and it's ready for the autoclave. This is our tabletop autoclave. I'll be loading a pack in just a second and showing how exactly to start the sterilization process, but first I just want to describe how it works. So, autoclaves use steam under pressure to kill microorganisms. So what happens is we load the machine with distilled water in the water port. The water is heated up electronically to a temperature of about 270 degrees Fahrenheit. Once the water is heated up, it will be turned to steam, and the steam will push out any extra air. And when the air is gone, there'll be a buildup of pressure. So the pressure builds up to about 27 psi. And then the steam is used to clean and sterilize the packs, penetrating upwards through this tray here. So it's important when you're loading the pack to not overcrowd the autoclave, because if the autoclave is too crowded, then there won't be proper sterilization, there may be moisture buildup. So you always want to make sure there's not too much in here, there's room for the steam to kind of penetrate the packs. Make sure there's a couple, if you're doing more than one pack, there's a couple inches in between. They're not stacked. So this pack's pretty large, so I'm just going to run this one pack here. You kind of close the door and seal it. It has a gasket seal on the inside. There's a few settings on this autoclave, for example, unwrapped instruments and glassware, but we're going to be using the wrapped pack setting here. And once we seal the door here, all the way, you go ahead and press start. Now, it's definitely important to do maintenance on your autoclave. We do weekly, monthly, and yearly maintenance. Once a week, it's a good idea to clean the autoclave, including the gasket door, which I'll just open back up here. With a mild detergent, we'll wipe the door, the interior of the chamber, we'll take the tray out and clean it. And probably about once a week, we will do a cleaning cycle. So we use a product called Chamber Bright, in which you pour in a powder product and you run a sterilization cycle without a drying cycle. And then when you're finished, you'll drain the water from this spout here and replace it with new distilled water. Another thing we'll want to check about once a month is the seal on the gasket. Just check for any damages. About once a year, we'll actually replace this gasket so we have a nice seal, as well as the air filter, which is on this side here, just to make sure there's no spores building up, which is another thing that we do, is bactericidal spore testing. So it's important to keep up with maintenance on your autoclave, and because you don't want to have any problems with sterilization. We have a binder log that we fill out, like I said, every week to every month, and then once a year we perform those tasks. So once my autoclave is finished running, which takes about 45 minutes. It's probably about 15 minutes to heat it up to that temperature of 270 degrees, the sterilization step, and then the drying stage, where the door will open slightly and let out any extra moisture and condensation. And then when this is finished, I'll take my pack out and show you how to check for sterility. My autoclave is finished running and I've removed my packs. I can check to make sure that they have become properly sterilized. So I'll look at my indication tape here, which has the black stripes. So that was my gown and towel pack, and then my general orange surgery pack also has the same black stripes. So just to make sure that the products had become sterile, I would check that tape. I would also check for any moisture or condensation. Sometimes with the packs that we wrap with the view reel, you can see if they're not properly sterilized, you can see some water bubbles on the inside. Now that would be a cause for you to unwrap the pack, rewrap it again, and rerun it because the item would not be sterile. You would just want to make sure that you've sealed the pack properly, that you ran your autoclave and packed it properly, just to avoid that problem again. I'll be demonstrating suture needles, materials, as well as suture patterns. Suture needles have three components: the needle point, the body of the needle, as well as the suture attachment end. Needles that have eyes on the end can either be closed or French style. With these eyed needles, the suture is threaded through the eye. However, with swage needles, the suture already comes preloaded during manufacturing. The swage needles are the most common because they're easy to use and there's limited trauma to the tissue because the suture is preloaded. The bodies of the needles can come in different shapes. I have here a straight needle, and then we have a curved as well as parts of a circle. They include the 5/8, the 1/2, and the 3/8. The straight needles aren't used too often in veterinary medicine since they can only be used in locations where the fingers can be used to pass the suture. But one use for them is to place a purse string suture in the rectal area. Curved needles can be used elsewhere as they can be manipulated by the needle holders. When choosing the size of your suture needle, the veterinarian will consider the tissue thickness and depth of the incision, but it's best to use the smallest needle that can effectively reach both sides of the incision in order to decrease the needle-induced tissue trauma. The point of the needle is important, and I have several types here, as it determines the type of tissue which it should be used. Needle points can be classified as either cutting, tapered, or blunt. Cutting needles have 3 cutting edges on the point, and it's denoted by the triangle cross section. This type is useful for tough tissue because the cutting edge on the inside of the curve cuts towards the edges of the wound, and that can compromise tissue strength. A reverse cutting needle is stronger than the conventional cutting needle, and it has one of the cutting edges on the outside of the curve, as you can see here, and it's also denoted by a triangular cross section. The taper point needles, which are here, contain a sharp tip that's capable of piercing and spreading tissue, but since the cross section is rounded, it does not cut the surrounding tissue. So anytime a sealed suture is needed and the tissue is not difficult to pass through, a taper needle can be used. Taper point needles can be used in the intestines, fascia, and subcutaneous tissues. A taper cut needle is a little bit different. It's a combination of a round taper body and a reverse cutting point. It can be used with tough fibrous tissue and some cardiovascular procedures. Blunt point needles here have a tapered body with a round blunt point. These needles can dissect through friable tissue without cutting and are generally used for suturing the liver and kidney. There are many different types of suture materials available. Sutures are designed to hold together tissue. When selecting the suture type and size, the veterinarian will take into account the patient's size, the area of placement, the strength required of that area, the healing potential of the tissue, as well as the cost. The sizing of the suture material is classified with the term aught, which is represented by a 0 here. The more zeros in a size, the smaller the suture. So this 6-0 would have 6 zeros, but it's written as 6-0. So it's smaller than, say, the 3-0 size suture here. Sizes can range from 11-0 to number 5. Smaller patients and more delicate tissue, like in ophthalmology procedures, tend to require the smaller sizes, whereas the larger sizes, like the 0 here, are used in larger animals. Either way, the suture selected should be at least as strong as the normal tissue through which it's being placed. So sutures are classified according to their type of material, which can be natural or synthetic, their biological behavior, which can be absorbable or non-absorbable, and their type of structure, which could either be monofilament or multifilament. Multifilament suture has 2 or more strands braided together to form a single strand of suture. Monofilament suture only consists of 1 solid strand of suture material. As you can see, the type of filament here is listed on the suture. We have braided as well as monofilament. Monofilament suture tends to have less tissue drag than multifilament, but it has the tendency to be slippery and become untied. Multifilament suture tends to have less knot slippage, but it has greater capillary action, which makes them more susceptible to bacteria colonization as compared to monofilament. For this reason, multifilament should not be used in contaminated wounds. Non-absorbable suture is not broken down by the body and can remain intact in the body for at least 2 years, like I have my nylon here. Absorbable suture is broken down by the body through different processes and may begin as soon as 7 days after placement, like my monocryl here. Absorbable sutures, like the monocryl, tend to be used inside of the body where the processes of absorption can take place. But non-absorbable sutures can be placed on the outside of the body, like the skin, and in places where high tensile strength is needed for long periods. So the first example I have here is a picture of a natural type of suture, which is silk. It's a multifilament, non-absorbable suture. It has exceptional handability because it has no memory. However, it can cause intense inflammatory reactions and it does not have the best strength. It can be used for vessel ligation because it doesn't tend to slip off of the vessels. Now we're moving on to the synthetic types of sutures. I have several here. The first is the polyglactin 910 or the Vicryl. This is an absorbable multifilament suture, as you can see. It has good handling and does not cause much tissue inflammation. It's a good suture for subcutaneous tissue closure as well as vessel ligation. The next is the polyamide or the nylon. It's available in both multifilament and monofilament forms, but I have the monofilament form here, and that's typically the more commonly used. It is non-absorbable. It has no capillarity and causes minimal tissue reaction. However, it can have poor handling characteristics and knot security. Nylon is a good choice for skin closure. Moving on to the next, we have the monocryl or the polycaprone 25. This is a monofilament absorbable suture. It is a good suture choice for rapidly healing tissues since the tensile strength does lose strength rapidly. For example, at about day 14, it's lost about 80% of its tensile strength. We use this a lot at our hospital. It's a strong suture, but typically it's used for rapidly healing tissues such as the urinary bladder as well as the subcutaneous tissue. Lastly, I have the surgical steel. It's a non-absorbable metallic suture. This is a monofilament, but it's also available in multifilament. It has the greatest knot security and tensile strength of all suture materials and does not produce an inflammatory reaction. It is hard to handle and may break or kink when handled repeatedly. Steel can be used in wound closure even if the wound is contaminated or infected. On to the suture patterns. Suture patterns can be categorized by the way that they oppose tissue edges, such as appositional, everting, or inverting, as well as the method of placement, which can include interrupted or continuous. I have my suture pattern pictures here separated. These are the continuous and these are the interrupted. The first common pattern is a simple continuous pattern. It's used quite often and consists of a knot at either end with continuous suture in between. This pattern can be used in the subcutaneous layer as skin suture on muscle layers or on the linea alba. It makes a relatively air or fluid tight seal. The next example is a forward interlocking pattern. It's another continuous pattern creating a strong suture line. It's usually used in large animal surgery and especially good for cow skin closure. Next, I'll go over the interrupted patterns. The interrupted patterns are beneficial because if one suture breaks, the whole line would not fail given that they're interrupted. The simple interrupted pattern is very commonly used and easy and versatile to place. It can be used to close the skin, muscle layers, subcutaneous layers, and can also hold Penrose drains in place. The horizontal mattress pattern here is a good suture pattern for areas of tension such as the elbow or hock. However, it can be time-consuming to place, and if pulled too tightly can result in an everting pattern. The cruciate pattern here is a modification of the horizontal mattress pattern. Its name comes from the fact that when these sutures are passed, they create an X shape. It also helps resist tension and results in a strong closure. The vertical mattress pattern, also called the far, far, near, near, is another good suture pattern in areas of tension. Like the horizontal mattress, it takes time to place, but it has fewer incidences of everting tissue edges. I'll be removing sutures. This is a patient that had knee surgery. So as you can see, the incision is fully closed and we're a couple weeks post-op, so we're okay to go ahead and remove the sutures. So indications that we wouldn't remove if we saw any signs of them being open or any discharge, swelling, anything like that, but always get the okay from the doctor to go ahead and remove.